Is your cold making it hard for you to get to sleep and leading to a bad morning? Switch to Mucinex Night Shift for fast, powerful nighttime multi-symptom cold and flu relief. Mucinex Night Shift fights your worst nighttime symptoms to help you get to sleep and wake up ready to go. Mucinex Night Shift. It's comeback season. Use as directed.
Well, hello there. I'm Nurse Mo, and this is the Straight A Nursing Podcast, where I teach concepts and share tips on how to thrive in nursing school and at the bedside. Today, we're going to be talking about a situation that happens a lot in the clinical setting, and that is acute confusion. And we'll go through 4 patient scenarios, each having acute confusion for a different reason. Now, before we hop into that, let's take a quick minute for our listener shout out. And this one goes out to Heather. Heather says, for 18 months, I've listened and re-listened to Nurse Mo's podcasts well before I even understand much of anything she's even saying. Adding to my understanding with each prerequisite and each podcast through the TEAS test, trudging along through the application process until finally I'm 3 weeks from my first semester of nursing school. Today, I was excited to purchase and start Nurse Mo's boot camp. I picked up the Med-Surg program and study sesh as well. For some reason, it all now feels real. Well, Heather, thank you so much for sharing that. I love that you started listening to the podcast way before you even started nursing school. It really can help you, even just as a pre-nursing student, help solidify your decision to continue on this path. And then once you start school, you won't be hearing the concepts for the very first time. So I'm really proud of you for taking the initiative and doing that, and for jumping into Crucial Concepts Bootcamp, Med-Surg Solution, and Study Sesh. So if you are interested in these programs that Heather is talking about, I'll put a link in the episode notes. You can always just go to the Straight A Nursing website at straightanursingstudent.com and click on courses in that top menu bar. Alrighty, let's talk about acute confusion. And we're going to bring this to life with 4 patient scenarios. I should emphasize that these 4 situations that we're going to talk about are not the only causes of acute confusion. So anytime your patient has a change in level of consciousness, becomes confused, anything like that, you're going to evaluate thoroughly. So our first patient is Phyllis. Phyllis is a 76-year-old widowed female with a past medical history of atrial fibrillation, hyperlipidemia, hypertension, type 2 diabetes, migraine, cholelithiasis, and post-operative nausea and vomiting. According to her family, her home medications are taken like clockwork each and every morning and include apixaban, simvastatin, metoprolol, metformin, a multivitamin, and omega-3 fish oil capsules. So apixaban, you also probably know this by its brand name Eliquis. She's taking that for the atrial fibrillation. Simvastatin is a statin, easy to recognize because it ends in statin. She's taking that for her hyperlipidemia or elevated cholesterol levels. Metoprolol is for her hypertension and can also maybe help some with the rate control in atrial fibrillation. So there's 2 reasons she might be taking that medication. Metformin is an anti-diabetic medication. And like a lot of people, she takes a vitamin and some supplements. She recently fell at home and was brought to the emergency department at 5:30 this morning for severe hip pain. So what do you think happened with Phyllis? Yep, the x-ray showed a fracture of the femoral head, and so Phyllis underwent a surgical repair at 08:30. Now, to help prevent postoperative nausea and vomiting, the anesthesiologist administered 10 milligrams dexamethasone as well as 4 milligrams ondansetron prior to reversing the anesthetic. This is very, very commonly done in surgery. In the recovery room, she received 50 micrograms of fentanyl, and a 10 milligram oxycodone tablet, as well as 4 units of insulin for a blood glucose level of 215. Since arriving from PACU to your room where you're the nurse at 11:15, she has been awake, she's been oriented, and she's been talkative. Pain has been controlled with hydrocodone and ice. Unfortunately, she has been complaining of nausea throughout the shift. For this, she has received 1 dose of ondansetron, also known as Zofran, and 1 dose of metoclopramide, also known as Reglan. You've also been doing some non-pharmacologic interventions for the nausea, such as a cool cloth to the forehead and encouraging slow, deep breathing and just keeping a nice, calm environment. She declined to eat lunch, and it is now 18:30, so right at the end of your shift. You enter the room and notice she has not touched her dinner tray at all. You ask Phyllis if the nausea has returned, and she looks at you with confusion, saying, "Where's my husband? And who changed my bedroom around?" You ask Phyllis some clarifying questions, and while she is able to state her name, she does not know where she is. She's unaware that she had surgery and cannot state the year. So, we've got a patient who has acute confusion. So, what is our priority assessment with Phyllis? So, considering Phyllis's past medical history, we are very, very concerned about hypoglycemia. Whenever a patient takes any kind of anti-diabetic medication and they have acute confusion, you're going to be thinking very, very quickly about hypoglycemia as the cause. So, you check Phyllis's blood glucose level and get a result of 38. Now, considering this data, that blood glucose level of 38, what is your priority intervention for Phyllis? So, with that confused patient who's also hypoglycemic, your priority, first off, is patient safety. You cannot leave her alone. I would not leave Phyllis alone at this time. She's at very high risk for getting out of bed and really doing a number on that fresh hip that she just got operated on. She could fall, she could mess up the surgical site, all kinds of things. So I'm going to stay with Phyllis and call a coworker to grab me the medication that Phyllis needs. And what medication is that? That's going to be dextrose. And because her blood glucose level is so low, we're not going to be giving the juice like we do for a patient that maybe has a blood glucose level of like 67 or so. We're going to go ahead and give IV dextrose. We'll give that IV dextrose, and we're going to stay with Phyllis and recheck her blood sugar in 15 minutes. So now let's think about why we think Phyllis had this particular problem. So we look back at her medications. Remember, we heard from family. Mom is so great about taking her medicine first thing in the morning when she gets up, like clockwork. So there's a very, very, very good chance she took her medications this morning. And one of those medications is metformin. She likely took that, then fell and broke her hip, and then came into the hospital. She also subsequently received 4 units of insulin in the recovery room. And she hasn't eaten anything all day, likely since last night. Now, oral antidiabetics like metformin and insulin carry a high risk of hypoglycemia when they are utilized together, especially when PO intake is low, as it has been with Phyllis. The other key question to think about with Phyllis is, why was her blood glucose elevated in the recovery room? She took her metformin, she hasn't been eating. Why was she hyperglycemic at that time? So there are 2 reasons why her blood glucose was elevated in the recovery room. One is simply the body's response to stress. It's going to cause an elevation in blood glucose. And the other, and probably the more likely culprit and why it was so high, is that she received dexamethasone as one of the medications to prevent nausea and vomiting. Dexamethasone is a corticosteroid, and it definitely increases blood glucose levels. So now that we've established that she was hyperglycemic in PACU, she got some insulin, she probably took her metformin, she hasn't eaten all day, she then became hypoglycemic. Why didn't she exhibit those common signs and symptoms of hypoglycemia? The tremors, the anxiety, the heart palpitations, all of those things. Well, beta blockers can mask the signs and symptoms of hypoglycemia. And since we're pretty sure Phyllis took her morning meds, one of those was metoprolol, which is a beta blocker. So that was your first scenario, your patient Phyllis, who had acute confusion because of hypoglycemia. Our next patient is Stanley, and Stanley is an 84-year-old man with a past medical history of hypertension, COPD, osteoarthritis, BPH or benign prostatic hyperplasia, diverticulosis, and cataracts. He developed severe abdominal pain while having dinner and visiting at his daughter's house and was brought to the emergency room. Stanley was found to have a small bowel obstruction causing some ischemia, and he had to go to surgery. Prior to surgery, the anesthesiologist performed an ESP block, which is an erector spinae plane block, which can provide pain control for up to 24 hours. Basically, we're putting some numbing medicine, some local anesthetic near the site of that surgery. And for Stanley, it worked really well. Pain was well controlled in the recovery room, and Stanley gets to his room around 01:15 in the morning. At about 4:30 in the morning, his daughter, who wanted to stay at the bedside, comes to the nurse's station to inform you that dad's now experiencing some pain, rated at a 5 out of 10. So you go in there, you give 2 milligrams morphine to Stanley, you stay with him for a few minutes to make sure he's not getting too sedated or having any respiratory depression, or maybe he needs some supplemental oxygen because morphine can have that effect. When you feel he's safe, you go back to the nurse's station. After about 30 minutes, the daughter comes back out to the nurse's station to let you know dad's now itching quite a lot and it's keeping him awake. So we know that opioids can cause pruritus or itching, and one of the medications we give for that is diphenhydramine or Benadryl. So you give 25 milligrams IV diphenhydramine and assure Stanley and his daughter that this will take care of the itching and allow him to get some rest. Well, not so fast. 20 minutes later, the daughter calls out for help. You hurry into the room to see Stanley trying to get out of bed, stating he has to get to the bakery before all the good donuts are gone. He's able to state his name, but is disoriented to time, place, and situation. Thankfully, he does recognize his daughter as someone he knows, but keeps calling her by his ex-wife's name. With some effort, you and Stanley's daughter are able to convince him to get back into bed, though he continues to be restless and confused. So what do we think is going on to cause Stanley's confusion? So considering the timing of the onset of confusion, I'm very suspicious that it was the morphine and the diphenhydramine. Both of these medications separately can cause acute confusion in the elderly, and when taken together, that risk is going to be much higher. So that's what I'm considering: an opioid and diphenhydramine. What else would we want to assess with Stanley? Now, even though we're pretty sure the culprit is the medication, let's go ahead and check a blood glucose level. Let's make sure he's getting enough oxygen to his brain. Let's check an oxygen saturation level, and we'll do a quick neuro assessment to evaluate if Stanley is showing stroke symptoms. Thankfully, his blood glucose is within normal limits. His SpO2 is 98% on room air, and your BFAST assessment reveals nothing that indicates stroke. Okay, so it's just confusion, most likely related to medication. To help Stanley, we're just going to keep his daughter at the bedside. We're going to keep a really close eye on him. We just need these medications to wear off, basically. We want to just make sure that he stays safe. We will reorient him as needed and just do our best to get him to stay in bed and try to get some rest. Now, many medications can cause acute confusion, especially in elderly individuals. There is something called the Beers List, which is a compilation of medications that are known to basically be high risk for causing problems in elderly patients, where the risk really outweighs the benefits. And acute confusion is certainly a complication that we're going to be concerned about. Other medications that can cause acute confusion in the elderly are tricyclic antidepressants, antipsychotic medications, benzodiazepines, that's a big one, and meperidine. Learn more about the Beers List by checking out episode 169.
It's intern John. Celebrate the coziest season with Safeway. They bring all the fall flavors to you, from pumpkin everything to caramel apples and all of your seasonal favorites. Make the most of those fireside dinners, game-winning touchdowns, and warm family gatherings. All you gotta do is visit your neighborhood Safeway today or shop online for easy pickup or delivery. They're here to help you spice, season, and savor every moment. Sincerely Safeway, your favorite local supermarket.
All right, patient number 3 is Bob. And Bob is a 64-year-old male with a past medical history of hypertension, COPD, peripheral vascular disease, recurrent cellulitis, and coronary artery disease. He's in the hospital for a COPD exacerbation and pneumonia. When you first come on shift at 1900, you take Bob's vitals and you see that his heart rate is 72, his respiratory rate is 14, his SpO2 is 93% on 2 liters nasal cannula, and his blood pressure is 142/76, and his temp is 36.8 degrees Celsius. You administer his 2100 meds a little bit later and get Bob all tucked in for a good night's sleep. Everything is going according to plan until around 2 a.m. You enter Bob's room to take a set of vital signs. You notice he's removed his nasal cannula, taken off his gown, and is kind of stuck at the bottom of his bed, all tangled up in the blankets. At least he hasn't also removed his IV. What ensues is an hours-long struggle to get Bob to wear his oxygen, leave his clothes on, and stay in bed. Every time you get him settled, he quickly becomes agitated and restless again. Now, when you ask him orientation questions, he knows his name, he knows he's in the hospital, but he doesn't know why he's there or what day it is, and he certainly doesn't want to wear that nasal cannula. So what assessment data do we want from Bob? Now, since Bob is there for a respiratory disorder and has that COPD, we really want to get a set of vital signs, especially that SpO2. You measure the SpO2 and are pretty shocked to see that it's only 81% on room air. That's pretty darn low. Now, if we really wanted to get into the details of Bob's oxygenation status, then an ABG may be utilized. An ABG is going to tell us the oxygen level in arterial blood, as well as other key information such as the body's pH and carbon dioxide levels. So now that we have a little bit of data, do we know what's causing Bob's acute confusion? Based on his medical history and an SpO2 of 81%, we're pretty sure his acute confusion is due to hypoxia. His brain is simply not getting enough oxygen. Ironically, patients who experience low oxygen levels, get hypoxic, often remove oxygen delivery devices because of the confusion, which allows the condition to quickly progress. So let's say we did get an ABG on Bob. What would we expect to see? Well, since Bob has a history of COPD that has been exacerbated by an acute infection, we're going to expect the ABG to be abnormal, especially with that SpO2 of only 81%. So that will be reflected in the PaO2, which will be decreased on the ABG. And the CO2, or the carbon dioxide level, is always generally elevated in patients with COPD. Now, it could be even higher than normal because of his COPD exacerbation that is going on. When the CO2 is elevated, this can cause the pH to be abnormal, so he may also be a bit acidotic as well. So, what is the treatment for Bob? The treatment for Bob is more or less going to depend on the CO2 level. If the CO2 level is elevated, and typically what will happen when the CO2 gets markedly elevated is the patient will become somnolent. And Bob's not at that point yet, but it doesn't mean his CO2 is normal. So if his CO2 is elevated and his O2 is low, he's going to get BiPAP. Now, if CO2 is normal, which may or may not be the case, we could improve Bob's confusion with oxygen administration, but we've really had a hard time getting him to wear his nasal cannula. So we might want to first try a different delivery device, such as an oxymask, which is, for some patients, a lot more comfortable. It doesn't stick in the nose, it doesn't wrap around the ears, so they may tolerate that a little bit better. So the treatment for Bob is going to be supplemental oxygen and BiPAP if needed. And I will say this is a clinical scenario that I saw play out over and over again in the medical ICU. A patient would get restless, confused, agitated when hypoxic, become somnolent, CO2 is now up, we put them on BiPAP, the CO2 clears, oxygenation improves, they perk up, don't want to wear the BiPAP, take it off, get agitated, get restless, CO2 rises, become somnolent, get the BiPAP back on, and over again. So anytime your patient who is having respiratory issues, receiving supplemental oxygen, anything like that, where you suspect that hypoxia could be the cause, if they experience acute confusion, make sure you check those vital signs, get an SpO2 level, maybe advocate for an ABG, and figure out a plan for ensuring your patient gets the supplemental oxygen that they need. Alrighty, our last patient is Meredith. Meredith is a 53-year-old woman with a past medical history of hypothyroidism, cholecystitis, uterine fibroids, and hyperlipidemia. She presents to the emergency room at 10:17 with a cough, shortness of breath, chest pain, and a fever. Her family tells you that she's been confused all morning. Upon examination, she appears a bit lethargic and is disoriented to place, time, and situation. You obtain a set of vital signs which reveal a heart rate of 119, respiratory rate of 25, SpO2 of 87% on room air, and blood pressure of 88/63. Her temperature is 38.9 degrees Celsius. Since you know confusion could also be related to hypoglycemia, you want to get a blood sugar as well. You check that and are surprised to see it is 215. So what is likely causing Meredith's confusion? So when we look at her symptoms, when we look at her vital signs, she looks like she has an infection, specifically a lung infection like pneumonia. And even beyond that, she is showing signs of sepsis. So sepsis signs are going to be, in Meredith's case, she has a known infection. We've already kind of discovered that. She has tachycardia, tachypnea, decreased SpO2, which would also be related to the pneumonia, hypotension, a fever, confusion, and hyperglycemia. It's like a giant neon sign flashing over Meredith's head that says sepsis, sepsis, sepsis. So what is the treatment for Meredith? Now, the treatment for sepsis can be very, very complex. The key things are source control when possible, fluids and antibiotics. So when I say source control, let's say that the sepsis cause was an indwelling urinary catheter. We would get that urinary catheter out right away. If it's an infected wound, the patient would have the wound cleaned and surgery right away. In Meredith's case, source control doesn't really apply because we can't take out her lungs, right? We're not going to be doing that. So the key things are going to be fluids and antibiotics. In addition, Meredith is going to get blood cultures and a sputum culture obtained, and it is absolutely critical that we do this before we start the broad spectrum antibiotics. We'll also support her oxygenation with supplemental O2, treat her fever and pain, and get her admitted as soon as possible. Now, of course, I very, very much simplified it here. Sepsis can be very complex and very challenging to treat. If you are curious about what it all entails, then I want you to check out episode 243, where I go into the sepsis bundle and all the components of that. So there you have it, 4 cases of acute confusion. We had Phyllis, who was confused because she had hypoglycemia. We had Stanley, who was confused because of medications that we gave him, especially medications that can cause confusion in the elderly, specifically that diphenhydramine with its anticholinergic effects. Then we had Bob, who was confused because of hypoxia. His brain was not getting enough oxygen. And then Meredith, who got confused because she had sepsis. So again, these are not the only reasons for acute confusion in your patients. I will tell you, and this will probably show up on an exam in nursing school, and you'll see it all the time in the clinical setting, especially if you work in the ER, a key sign of UTI in the elderly is acute confusion. So you have a family bringing in their elderly family member to the ER saying, I don't know what's going on. Mom's generally with it all the time, but today she is just so confused. And this can be really concerning for families because, anytime you have an older family member, you see signs of confusion, you really, really hope that it's not the onset of dementia and a long-term problem. So what we see a lot is these older patients, they come in, acute confusion, and the cause? They have a UTI. So put that in your sulci in your brain, and hopefully it comes back out when you need it on an exam or in real life. Now, if you are like Heather, who I mentioned at the top of the episode, and you're listening to this podcast before you even start nursing school, then there's a good chance that you're a wee bit nervous about it, right? That's why you're doing this extra prep by listening to the podcast. Then I would love to invite you to view a free video training type thing that I made called How to Thrive in Nursing School Without It Taking Over Your Life. You can sign up for that easily. Just go to my website, straightanursingstudent.com/thrive, and you can sign up for it. It's free. You'll get immediate access to it, and it will dispel some common nursing school myths for you. And I will also put a link to that in the episode show notes. So I hope to see you back here next week. We'll be diving into more nursing concepts. So I'll see you soon. Bye for now. This podcast is brought to you by Straight A Nursing, a proud member of the Airwave Media Network. For more educational podcasts, check out airwavemedia.com. And for more nursing-related content, go to straightanursingstudent.com.
At a time when change is constant and we are pulled in far too many directions, we need a way to stay present to life and to increase our ability to remain calm, think clearly, and maintain our well-being. Many studies indicate mindfulness improves our mental, emotional, and physical health. On a Mindful Moment with Teresa McKee, you can learn how to practice mindfulness and enjoy its many benefits. Tune in for guided meditations and to hear tips and advice from some of the most respected experts in the fields of mental health and mindfulness. The world truly can be a better place. It all starts with a mindful moment.